Great, thanks. It's great to be here, and I'm going to warn Marcia, I'm actually not doing the WHI data this time. I'm going to talk about other issues, but that is very important and very key research that we're continuing to look into specific aspects. So I'm going to be talking about sex differences in lung cancer in the era of targeted therapy. And let me see if I can get that to advance. There we go. And whenever I talk about lung cancer, regardless of the overall topic, I like to start with the concept that lung cancer is the leading cause of cancer death for men and for women. There was a big news splash at the beginning of February that lung cancer was now the leading cause of death for women in the developed world, but that wasn't really news. We've known that for a while, and we particularly know that in the US. And so this is just a graphic showing that, and you can see right up here, lung and bronchus, leading cause of cancer death for women, over 70,000 deaths a year. That's compared to 40,000 for breast. So it's not just a little bit more. It's really the major cause of cancer death. And when we look at the causes of lung cancer, I'm not going to spend a lot of time on this, but smoking remains the #1 cause of lung cancer. And this graphic illustrates that. You can see in the green, this is smoking consumption, or cigarette consumption, and then the cigarette consumption went down after the 1960s with the first Surgeon General's report, you can see here. And in gray, you can see that the mortality from lung cancer in men followed that as well. But women didn't actually stop smoking in the 60s. Their rates actually increased over the 60s into the 70s, and you can see that the lung cancer mortality increased as well, so that it's just now plateauing, but still hadn't dropped the way it did for men. There's also the issue of lung cancer in never smokers. So while lung cancer is predominantly caused by smoking, there's a large number of patients who get it who don't have a smoking history. We see that more in areas like where we are, where there's less smoking. So probably more than half of my patients have never smoked. When I talk to my colleagues in North Carolina, they're not seeing that quite as much, so it is somewhat regional, but a large percentage have never smoked. And when we look at Asia, in Asia, 60 to 80% of the women with lung cancer have never smoked, and we see that in our Asian Americans. We're doing a lot of work trying to look at those issues. We also see that in Hispanic women, there's less smoking in the people who are getting lung cancer, so we're trying to sort that out a little bit more as well. We do know that those who develop lung cancer who have never smoked do have a better survival, and a lot of that has to do with the genetics of the disease, which we'll get into later. Okay, so I'm now going to talk about some of the differences in treatment responses that we see based on sex. So this slide is showing a survival curve from a very famous study that was completed in the 90s that basically looked at patients newly diagnosed with advanced stage lung cancer, and they were randomized to get one of 4 different chemotherapy regimens. And you can see that none of those regimens did any better than any of the others, and unfortunately, none of the patients did very well. So this is months of survival, and there are very few patients making it out to this 2-year mark, and if you look at the 1-year mark, you've already lost the vast majority of patients. So a lot of room for improvement, and just at first glance, we don't see any differences here. But we went back into that data set and we divided it up into male and female cohorts, looked at the known prognostic factors as well, and then calculated response and survival differently by the sex cohorts. And you can see here that there was a 19% response rate to the chemo, regardless of sex. However, the survival was quite different. There was a 2-month survival improvement for the women. And 2 months, you might say, well, that's not very much, but keeping in mind the overall survival that was seen in the study, that was actually a pretty substantial improvement. And there have been many pharmaceuticals improved based on 2 months improvement in survival. So, this was a real difference and highly statistically significant. And we had looked at a lot of known prognostic factors and couldn't find anything else that explained this. So this is the survival curve showing a small separation. Okay, and when we looked at toxicity, what was interesting is that women actually had more toxicity from the chemotherapy, and that led to some hypotheses. Well, maybe they were just, they were processing it differently, it was different metabolism, and there's been a lot of work trying to sort that out, but no clear answers. So higher nausea, vomiting, alopecia, neurosensory. The only thing that was different for men was they had a bit more cardiac toxicity. Okay, so intriguing, no answers. So that was from a trial, the ECOG study. Eastern Cooperative Oncology Group is one of our major cooperative groups doing cancer research across the country. This other one is the Southwest Oncology Group, or SWOG. Don't ask why we're not in the Western one. We're in the Eastern one, but that's just historical. So the SWA group, they did a similar analysis. They didn't have one big trial that was 1,200 patients. They put a bunch of trials together to come up with 1,300 patients. And they were otherwise balanced. They also divided this up by sex. And then they looked also at age and tried to look at men and women at different age cohorts a little bit. And what they found was that the women in the yellow and the white did better than the men in the orange and the blue, but there was an age difference. So if you look at the men who were older didn't survive as long as the men who were younger, which is kind of intuitive. But counterintuitive was what was seen in women, where the oldest women, and over 60, so it's not all old, but older women, did better than the younger women. And these differences, it's not big, it's a month or two, but it was intriguing. And people started wondering, is there something about menopause that changes hormones? Does that change people's response to therapy? Does it change outcomes? So we went back and did a similar analysis from the Eastern Cooperative Oncology Group, 2 trials that used a similar chemotherapy combination where things were otherwise the same. And instead of just doing men-women, we did men-women, and we divided it up into different age cohorts. And when we did that, it was kind of intriguing. So if we look at the men in the white here, the youngest men of the men had a little bit better survival than the older men, but not statistically significantly so. So it went from almost 9 months to 7 months. But when we looked at the women, again, it was this inverse relationship. If you look at the youngest women under 45, it's small numbers. It was only 37 patients, and so we weren't fully reaching statistical significance. But this is quite a trend. It was 7 months for the youngest women and nearly 12 months for the women over 60. So again, do we have an answer as to why this is? No, but it's something that we've spent a lot of time trying to look at. And again, since I only had 20 minutes, I didn't put up all of the data that we've done trying to look at hormone differences. Is it estrogen? Is it progesterone? Is it something else? And the reason I didn't is because the answers all go like this, and we don't have a clear understanding of it right now. But we're trying to get closer to it. Okay. So moving on from that now, what about these newer drugs? So we've talked about chemo and chemo differences, but chemo's not all we use to treat lung cancer anymore. So one of the drugs that we've been looking at, and one of the pathways is vascular. So vascular endothelial growth factor receptor, things that change the blood vessels of the tumors, angiogenesis. And so the drug that's been the most developed in that setting is bevacizumab, which is an antibody. And this was a big trial where patients were randomized to get chemo with or without the bevacizumab. And so we went back and did the same sort of thing, looking at the men versus the women. And we showed that in both cases, for men or women, this drug significantly increased the response rate. It increased the time to progression. But in men, it added improvement in survival, overall survival, statistical significant hazard ratio. But for women, there was no survival benefit with this drug. So that was kind of confusing. It increased response and increased progression, but it didn't improve survival. So then we went back and divided it up by age. And again, interesting patterns emerged. So if you look at the men, whether they were under 60 or over 60, when they didn't have bevacizumab, they didn't live as long as if they did, right? So we added a little bit of time in both settings to the men. So regardless of age, men seem to benefit from this drug. But for the women, the youngest women had a profound benefit. They had a 4-month median survival benefit. 4 months, that's pretty good. But the older women, if anything, had a decrement. Again, these numbers are small. Some of these cohorts are smaller. It didn't fully reach statistical significance, but it got us really thinking about what does this mean? And is it something about the youngest women have a more aggressive tumor than is more benefited by this additional agent? Or is it that the oldest women over 60 are already doing very, very well from other biological issues and this drug isn't helping? Or maybe there's more toxicity. We still don't have answers, but again, very, very intriguing differences. Okay, so I titled this talk "In the Era of Targeted Therapy." I couldn't talk about this without setting the stage about what we already knew about sex differences related to chemotherapy, related to bevacizumab, but that's sort of how we used to treat lung cancer. It's still how we treat a lot of it, but where we've made the most advances is in understanding lung cancer from a biological standpoint, from the genetic differences in the tumor. And I'm going to use a particular example to discuss that. One slide first is just about P53, which does play a role in a lot of cancers, including lung cancer. Women smokers have a different types of changes in P53 than men, so they have more G to C versus T to A transversions. Okay, does that mean anything from treatment perspective? Not yet, maybe it will in the future. But I'm going to talk a lot about EGFR, epidermal growth factor receptor, because that's really been a paradigm shifter in how we think about lung cancer. So this is a cartoon, this is a cell surface. This is your tyrosine kinase known as epidermal growth factor receptor. And when it binds its ligand, it dimerizes, and it starts phosphorylating all sorts of things in the cell, which change gene activation, cell cycle progression, survival, angiogenesis. It's a very important protein in many cells, but particularly in the lung. And when it goes wrong, it can lead to lung cancer, which I'll tell you about. So we first learned about it because we knew that there was expression of this protein in a lot of lung cancers, and so drugs were developed that hit the EGFR, epidermal growth factor receptor. And then one of these is Erlotinib, and the first trial gave Erlotinib or a placebo pill and showed a little benefit, 2-month survival benefit, so this was exciting. But what people noticed was that not everybody responded the same. With chemo, even though I showed you those differences, it wasn't apparent to people treating. It was only apparent when we went back and did these analyses. But for people who were treating these patients, it was very apparent that women were more likely to respond than men, and that people who had never smoked were more likely to respond. And this led to further studies, including this trial, where they took patients who had never smoked, who had adenocarcinoma type of lung cancer, and who were in Asia, because there was also this difference by ethnicity. And they all happened to be women, or it was 90% women, because it was done in Asia. And as I told you, in Asia, most of the non-smokers with lung cancer tend to be women. Okay? So it ended up all being women. And they got an EGFR drug, different one, but same idea, versus chemo. And the first results of the study were really confusing, because for progression-free survival, the EGFR drug looked better, or it didn't look as good as the chemo at first, and then it crossed over, and this didn't make any sense. And survival wasn't any different. So we're like, well, maybe this isn't any better. But at the same time, people were doing more work to figure out, well, why is it that some people respond and some people don't? And that led to the discovery that for the patients who were having these phenomenal responses, they actually had gene mutations in EGFR, which were the driving force of their cancer. So we don't know why they got it, but we know that once that gene mutation happened, that's what led to the cancer. And so by shutting off the pathway, hitting EGFR, that's when you were getting these drastic responses. And they're fast. I mean, patients start taking the drug, they feel better within 3 days. So it's not one of those you wait 2 months and get a scan. It's they know, they come in to see you a week later, and you know that they're responding, and the scan just proves that. And so we've now come to make this a standard part of treatment, is that we look for these mutations. And when we find them, we can treat with these EGFR-focused drugs, and I'll show you why in a second. But these are some of the more common mutations. Again, 20 minutes, I won't go into all the details. But when we went back to that same data set of the EGFR drug versus chemo, it was very different when you looked at those with the mutation and those without. So now, those with the mutation, EGFR drug is much better than chemo. Those without, chemo is better. So we could clearly separate this out into different subsets, okay? And why is that relevant to this talk? Well, there are sex differences in the frequency of this. So women are much more likely than men to have this. So if you look at unselected patients with non-small cell lung cancer and you test them for EGFR, you're much more likely to find an EGFR mutation in women than you are in men, okay? And there are other differences. It's more common in those who've never smoked. It is more common in East Asia than it is in other parts of the world. And to kind of drive this home was this analysis that if you look at all lung cancer, non-small cell, 8% has an EGFR mutation. If you look at those with adeno, it's 10%. If you look at women, it's about 15%. Women who smoke, though, it's 11%. But women who don't smoke, it's over 50%. And if you go to Korea and look at non-smoking women for Korea, it's 60 to 70% of them have an EGFR mutation. And in my patient population here at Stanford, it's very, very high. So I always check for this. And it drastically changes our therapy. And this pie chart is now showing how we think about lung cancer. So the EGFR story I spent a lot of time on because that was the paradigm shifter. And now we think about looking not just for that, but for other gene mutations too. So we still don't know for a lot of our patients with adenocarcinoma what's that mutation that led to the cancer. And many people have more than one. But what's the key first one that really is driving the cancer? So EGFR is that 10% we talked about, bigger depending on the patient population. There's something called KRAS, which we still haven't quite figured out how to treat. But ALK, that was the second real big success story. When we know to look for it, we find it completely changes how we treat these patients. And then there's all these other smaller pieces. Some of these genes you might have heard of from other cancers, but they also play a role in lung cancer. Okay, so what about ALK patients? Are they like EGFR patients? Not exactly. Not exactly. There are more who have never smoked, but there's a good percentage who have smoked. And the male to female ratio is different. So instead of a strong female predominance, there's a small female predominance. And we did a review where we surveyed a bunch of oncologists around the country and said, well, what do your ALK patients look like? Because there was this perception from what we knew about EGFR that they were all going to be young, never-smoking women. And it turned out they're not all young, never-smoking women. That's actually a mix of folks. Some are in their 60s. Half were women, but half were not women. And 59% were white, but there was a large number of African American, Hispanic, and some Asian patients, but not that same predominance. So it's different. But the outcomes are the same. If you know they have ALK, you give them an ALK drug, it's much better than chemo. Okay, so what about other gene mutations? I showed you that pie chart. There are a lot of different gene mutations we look for now. For BRAF, and you heard about that a little bit today with melanoma, the same BRAF mutations occur in lung cancer, but in that setting they're driving the lung cancer and not melanoma, and we don't really have a good answer as to why a BRAF mutation would cause a melanoma in one set and a lung cancer in another, but it's the same gene mutation. 54% of all BRAF mutations found in lung cancer in this series were in women. For ROS1, it's similar to ALK, it's about half. KRAS, 2/3 are women. HER2, 70% were women. And this isn't HER2 from, it's the same gene you've heard about for breast cancer, but that's an overexpression. This is an actual gene mutation. It becomes the driving force. And when you put that in context, remember, only 32% of all the lung cancer in the world, or at least in the US, and those numbers I showed you are in women, but 45% of the lung deaths. Okay, so 32% of all lung cancer is in women, and yet when we look at all the lung cancer that has a BRAF mutation, it's half women or 70% women. So there is a bit of a female predominance in these, and we're trying to sort all that out. Perhaps it's a linkage with the never smokers. These tend to be more common in people who have never smoked, but we're not sure. Okay, and then just a little bit more with the KRAS. This was actually published this week. Even though we now know there's sex differences with the mutations, within those specific mutations, there's still sex differences in outcomes. So if you have a KRAS mutation and you have lung cancer and you're a man, you don't do as well as if you're a woman. Okay, so this is survival 1 year versus 1.4 years. It's not a big difference, but it is statistically significant. So there's still more to it than just the gene. All right, so I'm going to close just by showing you that pie chart again. And just by saying that when we talk about lung cancer, sex differences in lung cancer in the era of targeted therapy, we still have more never smokers with lung cancer or women as opposed to never smokers with lung cancer who are men. Once diagnosed, women do seem to do better than men with chemotherapy, with different therapies. We don't know why. And it's more for the women over 60 than the younger women. There are age-sex interactions with bevacizumab. There are some sex differences apparent in the frequency of the gene mutations in lung cancer, and sex is a stratification factor for all of our studies. So, thank you.
Wow. She hit it. So, okay, we have time for questions.
Okay, so in many of these studies, the subjects were divided into smokers and non-smokers. Was secondhand smoke controlled for? And if so, did it make a difference?
So the secondhand smoke story is a very good one and a very complicated one. And Marcia knows we've done a lot of work in the WHI trying to sort that out. It's a very different factor to tease out. Detailed secondhand smoke information is really not collected in most clinical trials. You really have to look at work like WHI to have questionnaires that have any level of detail on that. And then because there has been so much exposure for society over a long period of time, it's very hard to tease out those differences. So it's been tough to really make a stance on that. But great question.
Questions?
Oh, radon as a cause of lung cancer. We know that radon is a small but real cause of lung cancer. I have not seen any clear sex differences in that, if that's the question. We think it's probably 1 to 2% of all lung cancer.
Okay. Well, I also, if I remember correctly, most of the NIB and NAB drugs that you mentioned target lots of receptor tyrosine kinases, not just one. So have you looked at the other receptors or noticed any patterns there?
You mean as far as what is the frequency of some of those other, what the drugs are hitting, and if those are different? Yeah, so most of the drugs that I talked about, the Erlotinib and Gefitinib, are pretty specific for hitting EGFR. There's another EGFR drug that also hits HER2, because HER1 is EGFR, HER1 and HER2 are similar, called Afatinib, and that's actually the drug we're using for patients with the HER2 mutations. But as far as, do we have lots of data about sex differences as far as what the patterns are for those gene mutations? Not a whole lot. I mean, what I pulled out is what I was able to find, and you probably noticed that those case series tend to be fairly small, and that has to do with the fact that when we look at this pie chart, you can see that most of those are fairly low frequency gene mutations in lung cancer, and so we just haven't found enough patients with those, haven't looked at enough patients to really be able to say, well, is there a clear sex difference other than where it was very apparent like HER2 and where we have thousands of patients now with known EGFR mutations. Does that answer your question? Yeah. Okay. Yeah.
Did I see another hand up over here? Real loud.
I wish I did. No, we don't. And it really gets to the fact that, I mean, with P53, we have some theories about, what those mutations, how those mutations are getting there. But with these other driver mutations I was talking about, we don't know why people get mutations in EGFR and why we're seeing it perhaps more in the never smokers, or maybe we're not seeing it in the people who smoke because there are other reasons that are causing them to get lung cancer sooner, though some of these are young. I mean, there's lots of speculation about it, but we don't have a good answer for most of these.
Okay, thank you so much.